people don't have any, you're hearing me?
Yes, go ahead.
All
Sorry,
right.
the
Some
recording was
people will
late.
not have any periods at all for many years. So we call that amenorrhea. And those that have full-blown amenorrhea, it means that they are not ovulating. Because if somebody ovulate and don't get pregnant, as I explained before about the corpus luteum and the progesterone falling, and so they will have a period every month. So
Okay.
the having regular periods indicate that the person ovulating. Now, if people don't have regular periods, them have less than 9 hours of the year, we call that oligomenorrhea. Or if they don't have any period at all for years, we call that amenorrhea. So that is one thing that you should have in order to make the diagnosis. The second feature is features of androgenism. Androgens are male hormones, and the most common one in the polycystic ovary syndrome is something called testosterone. There are several others. I don't have to get into it. So just remember that androgens mean male hormones, and the main one is testosterone. So this is a condition in which the androgens are high. So the testosterone is high. So you will have some of the clinical features are manifestation of the high testosterone. All right. And some of these would be like, and it's male pattern. So if the testosterone high, it's trying to form mustache. So some of these women must having ear over the upper lip like mustache. They're trying to get beard. You might have hair on the chest. You might have hair on the lower part of the abdomen below the navel coming up from the pubic area going up to the navel. That is called a male pattern. Pubic hair. Most women are just triangular. All right. You might have acne because the testosterone is almost like fertilizer for the bacteria that cause acne and certain things in the ear follicles called sebum. So you get excessive secretion of the sebum and you could get acne. In bad cases, you could even get what is called male pattern balding or what they call alopecia. But it's more like how you see most men will start to lose the hair from the front here and go there. So you might have hair around the back. So a similar thing could happen. But that is not very common, but it can happen because of and that depends on how high the testosterone is. All right. And in bad cases, it may even cause the voice to get deepened. So that you find is a female, but she have a deep voice because of the high testosterone. Now the body here, the increased body here, the mustache, the beard, the male pattern thing, and so the term for that is called hirsutism. All right, and it is due to the high testosterone. Now the third thing is that you do ultrasound scan and the ovaries should look polycystic. And as I said before, they should be bigger than 10 cubic centimeters. It should have at least 12 stunted follicles. That mean like 2 to 9 millimeter in diameter, and they usually around the periphery. And usually it should be bilateral in both ovaries. So the ultrasound features are usually bilateral, greater than 10 cubic centimeter for the ovary. The follicles should be around the periphery. It should have greater than or equal to 12 of these small follicles. And all the follicles should be 2 to 9 centimeter, a millimeter in diameter. So if you have two of these, then we could say you have the syndrome. So say, for instance, people not having regular periods and they have all of the features, many features of the androgenism, but when you do the ultrasound scan, the ovaries look normal. This will still make the diagnosis because you have 2 out of the 3. You hear me?
Okay.
All right. So you will find
Two out of the 3.
Yes. So some people have the clinical features. They're missing the periods. They have the features of androgenism, but the ultrasound is normal. Right. They still have polycystic ovary syndrome. And you usually see this in the younger people, like in the teens and so. But as they grow older, then you will notice that the ovaries start to look polycystic. Okay?
Okay.
Now you have the other situation. You might see somebody might come to you with an ultrasound scan saying that they have polycystic ovaries, but they don't have the features. They're slim, they have regular period, they don't have any features of androgenism, and so in that situation, you shouldn't really make the diagnosis. You could say that they have polycystic ovaries, but you really should not say that they have polycystic ovarian syndrome,
Okay.
because they don't have the menstrual abnormalities or the features of testosterone. You following me?
Yes.
All
So
right.
if someone goes to the doctor,
Yeah.
you're saying the doctor shouldn't diagnose them with the ovarian syndrome itself, just polycystic ovaries.
Yes, and
But
they
if,
should just describe what they see. Because at the time you see now, the ultrasonographer will then say polycystic ovary and then put a report on it so that the person have polycystic ovary syndrome. And it can
okay.
start so much anxiety and generate so much, thing. And
And
when
the
them
wrong
come,
treatments.
well, the anxiety and if the doctor know what they're doing, they will explain things to the people. Because if the people have they're not overweight, they don't have any features of androgenism, they have regular period, they get pregnant every year and might have to be terminating, that person don't have polycystic ovary syndrome.
Okay.
You with me?
Okay. Yeah, got it.
Also, I've seen people come to me saying polycystic ovary syndrome from the ultrasound, but the ovaries are less than 10 cubic centimeter in size. So that person should not be labeled as having polycystic ovaries either, because you need the increased size. With me?
Yes, got
Okay.
you.
So it is important. So to make the diagnosis, we need to have 2 out of the 3, and this is called the Rotterdam criterion. All right. Now, there are some other things before we move on. So the risk factors, I would say, a significant proportion of it seem to be genetic, right? Because of the twin studies and with the first and second degree relative and the high incidence.
Okay.
All right. But so people can not have any genetic predisposition because they don't have anybody in the family who had polycystic ovaries and are so, but so there's a big environmental factor. So the environmental factors are anything that causes people to get obese, right, is tied up with this polycystic ovary syndrome. And you don't know if it's which one come first, is the cart or the horse. Because I think the obesity may increase the chance of getting polycystic ovary syndrome. But I think most of the time is the syndrome is the underlying problem that eventually lead to the obesity if people do certain things. So I will go through it. So the obesity, especially if people get obese pre-pubertally, before they start having their period. So if a child is obese before they start having their period, is a high chance that they will develop polycystic ovary syndrome. If they start having the periods very early, some 8 or 9, this is also associated with an increased risk of developing polycystic ovary syndrome. And the obesity and this one is also tied up because the people who tend to start the period very early, most of them are the overweight or obese people. Because if people are underweight and slim, it tends to delay the time of the first period. You understand that?
Okay. So you're saying if you're overweight early on in your life,
yes,
8, 9, 10, you tend to bring on
too.
those period. Or I didn't know that. Okay.
Yeah. All right. If you were large when you were born, so you are small, but the large more fitting. So if during the pregnancy the baby overgrow and it become what is called a macrosomic fetus. So when it born, it weigh more than 4 kilograms. These children go on to have a higher incidence of polycystic ovary syndrome. But paradoxically, those that were born small for dates too, so they were small when they were born, they also have a higher risk and incidence of polycystic ovary syndrome. And we don't really know exactly why this is, right? But
So
there are associated.
The extreme, if you're too small, if you're too large,
Yes.
then the risk increases. Wow.
All right.
Okay, I
There's
didn't know
also
that.
there is an anti-seizure drug, anti-epilepsy drug called valproic acid. And there's an association between the use of that and developing polycystic ovary syndrome. So say the child was epileptic and was using this drug to treat the epilepsy. There is an increased incidence of polycystic ovary syndrome in those people. Right? So this is an association, and I really can't explain it in terms of what we call the pathophysiology. Also, if the baby the embryo in utero was exposed to androgens, say the mother for some reason was exposed to androgens, testosterone or whatever, but those fetuses have a higher incidence of developing polycystic ovary syndrome.
Okay.
All right. So it could have been programmed from in utero.
Okay, because in the beginning you said there was no they didn't know what the cause of it was.
Yeah.
But I guess studies in recent times would have led to some of these conclusions.
No, we still don't know the cause, but I'm going to try to explain something called the pathophysiology, because I tell you, this is a very difficult thing for people to understand. It would be easier if I was actually talking to doctors and not dissing anybody. But, so to explain it, it would be easier if I was talking to doctors. You understand? Because they understand the endocrine system, they understand the menstrual cycle, they understand the adrenal gland, the pituitary gland, and the pituitary ovarian axis. So this thing, if you understand that, it's easier to tie up all the different things there, right?
Yeah,
I'm going to try, however. All right. So I think there's a strong correlation, apart from the things that I said before. There's a strong correlation with something called the insulin resistance syndrome. And in fact, some people believe that the insulin resistance syndrome is the factor cause of polycystic ovary syndrome. So we're blaming the ovary when the ovary is not the cause. The ovary is a victim of the insulin resistance syndrome. All right. And the insulin resistance syndrome is strongly tied up with something called the metabolic syndrome. So it's a continuum with all of these things. The metabolic syndrome could lead to insulin resistance syndrome, and the insulin resistance syndrome could lead to the polycystic ovary syndrome. So the polycystic ovary syndrome, I like to tell patients that it is a subset of the bigger syndrome, which is called the insulin resistance syndrome.
Okay.
You have that?
Yes, yes,
all
yes.
right. So you could have people who don't have a strong family history, as I said before, but because they have the insulin resistance syndrome, metabolic syndrome, obesity, all of this tied up, it could lead to polycystic ovary syndrome. So the pathophysiology is when you can explain. Pathology means disease, and physiology is what? Normal. So if the pathophysiology is as I attempt to try to explain how the physiology have gone abnormal that lead to the pathology.
Okay.
With me?
Yeah.
So here's a simple little thing, is like a vicious cycle. So we have insulin resistance for whatever reason, right? Sometimes we don't know what caused the insulin resistance. So let's just take it from this. Insulin resistance, the body going to try to correct that by putting out excess insulin. So the insulin resistance means that the insulin receptors are not very sensitive to the insulin. So if the receptors are not very sensitive, the pancreas will put out excess insulin, like trying to jumpstart the lazy receptors. You understand what I just said here?
Okay.
So the insulin resistance is going to lead to what we call hyperinsulinemia. Right. Now the hyperinsulinemia, if you have that and you fuel it by eating bad, you're eating what is called a high glycemic index diet. So things that have a lot of glucose are converted to glucose quickly. Like a lot of rice and flour and Irish potato and sweet drink and that kind of thing. If you do that, it will then lead to obesity, because what you have now, we have high insulin because of the insulin resistance, and then you eat that kind of diet that within 2 hours of eating plenty rice, flour, Irish potato, it converted to glucose. So we have high glucose and high insulin, and the insulin now, one of the main functions of insulin is to move the glucose from the bloodstream and to put it into the cell to be the fuel for the cell's metabolism. But the cell might need, I like to explain this so that people can understand in the office, that the cell might need 10, but because of the high glucose and the high insulin, we put 100 into the cell. So the cell going to use the 10 for its metabolism and then convert the 90 to fat.
Okay. And I
So
guess if you're
that's
sedentary,
why
if
a
you're
lot of people will go on to get obese.
right. And I guess if you're
That's overweight.
sedentary as well, you're not exercising, burning
Yes, all of that, the
burning that
sedentary
sugar.
lifestyle. So, so you see, it's a complex of insulin resistance and a poor diet. Those two got together to cause obesity, and then the obesity itself will then cause more insulin resistance. So you get into a vicious cycle.
Okay.
So the vicious cycle is insulin resistance lead to hyperinsulinemia. Hyperinsulinemia combined with a poor diet, and as you just said, a not active lifestyle, a sedentary lifestyle, it will lead to obesity, and the obesity in turn will cause more insulin resistance.
Okay.
You following me?
Yeah, and then how does that insulin
Because if you
resistance?
understand, then I assume that other people will be
Yeah,
understand.
yeah. And how does that insulin resistance now impact those ovaries to let them be polycystic?
Well, as I tell you before, is a difficult thing
It's
to
difficult.
explain.
Okay, all right. We won't. Okay.
I draw some kind of flow charts, and I'm going to try to follow this through now. All right. So if we start with insulin resistance, eventually you're going to have increased insulin, which is called hyperinsulinemia. The hyperinsulinemia will now positively stimulate some cells in the ovary, which are called theca internal cells. Right. Another thing with this polycystic ovary syndrome is that the luteinizing hormone, which I mentioned before, which is important for ovulation and for the functioning of the corpus luteum. In this syndrome, that luteinizing hormone is very high. Right. Another reason why we don't fully know. So the two main hormones from the pituitary gland that control the ovary is the follicle stimulating hormone and the luteinizing hormone. And in the normal situation, the follicle stimulating hormone to the luteinizing hormone ratio should be 2:1.
Okay.
Right? So it should have like 2 follicle stimulating hormone to 1 luteinizing hormone, a 2:1 ratio. Okay?
Okay. So ladies, you hear that?
In this syndrome, it is reversed. The luteinizing hormone is higher. It could be 2 to 3 times as high as the follicle stimulating hormone.
Okay.
All right. So in this thing, we start off with 2 things. So the 2 things are high luteinizing hormone and high insulin. The both of those will positively stimulate some cells in the ovary called the theca internal cells to produce androgens, because these are the cells that produce androgens. The Graafian follicle cells produce estrogen. So the theca internal cells produce androgens. Main one is testosterone. So a big part of this thing is excess testosterone. And the excess testosterone manifests itself in many ways. As we said before, it causes the hirsutism, that is the mustache and the beard and the hairy chest and the hairy abdomen. There is increased incidence of acne. The clitoris. The clitoris is the same embryological origin as the glans penis, the head of the penis. So the clitoris have testosterone receptors. So if the ovary overproducing the testosterone, if it's significant enough, it could cause the clitoris to grow bigger, which is called clitoromegaly. It's almost like it's trying to form a small penis. So some people will have a big clitoris. If the testosterone quite high, people could have a hoarse voice. Now, the androgens themselves can also add to the obesity, because the androgens, they can cause the muscle to grow and even the fat cells to grow too. So so it can cause some of the obesity. It can cause your lipids to change. So like it causes what is called dyslipidemia. So when the androgens high, it tend to increase something called triglycerides in the blood, and it also decrease the good cholesterol, which is called high density lipoprotein, and it increase the so-called bad cholesterol, which is called low density lipoprotein. You don't want this to happen, because if this is there and prolonged, this is associated with increased incidence of cardiovascular disease, increase your risk for stroke and heart attack and things like that. You following me?
Right.
Androgens, increased androgen can cause all of these things. Now,
Okay.
the increased androgen can also cause the liver to reduce the production of a protein, which is called sex hormone binding globulin. So two things can affect the liver to do this. The high insulin can cause the liver to decrease the production of sex hormone binding globulin, and the high androgen also cause it. So two of the things in this syndrome can reduce the sex hormone binding globulin. Now, this is a protein that the liver produces that binds estrogen and binds testosterone and other androgens too. So the most of the estrogen would not be free and the androgen would not be free. So when they're not free, they're not biologically active. You follow what I'm saying?
Okay. Okay.
So when
Yes.
you reduce the sex hormone binding globulin, what you do is you increase the free testosterone and the free estrogen. So they are more biologically active, meaning that they can cause certain stimulation of things.
Right.
You with me?
Right. And
All
you
right.
covered some of that last week in as far as the estrogen is concerned.
Yes.
Yeah.
So with the increased estrogen, the increased estrogen can have what is called a negative feedback on the pituitary gland. And that will cause the pituitary gland to decrease the amount of follicle stimulating hormone that it produces. So this now is part of the explanation as to why the ratio of the LH to the FSH can be 2 to 1 or even 3 to 1. Because the high estrogen negatively feedback on the pituitary gland and reduce the follicle stimulating hormone. And as I said before, the follicle stimulating hormone cause the follicles to develop and to produce estrogen and ovulate and things like that. You following me?
Yes, yes, yes.
All right. Now, so if the estrogen cause the negative feedback at the pituitary level, so we have decreased follicle stimulating hormone, what will happen is that the follicles that you're born with, which are in resting phase, they won't develop. And there's something called follicular atresia. They'll be dying off all the time.
Okay.
All right. So you're losing your follicles, and those that even start to develop, they're stunted. You have stunted Graafian follicles. None of them reach a centimeter. So if you have the follicular atresia and stunting, then you don't get ovulation, from what I was saying before, right? Because in the 28-day cycle and around day 14, the pituitary increase the luteinizing hormone, and that causes ovulation. But in this setting, you don't get any ovulation. And if you don't get the ovulation, you don't get the formation of corpus luteum. And as I said before, the corpus luteum main function is to produce progesterone. So if there's no corpus luteum, there is decreased progesterone.
Yeah, yeah.
All right. And the decreased progesterone is not good. One of the main problems in people who have polycystic ovary syndrome is that they have estrogen without progesterone, which, as I mentioned before, this is called unopposed estrogen stimulation, right? So if you have decreased progesterone, it's almost like you have de facto increased exposure to estrogen, right? And the estrogen is two types of estrogen. You have what is called E1 and E2. The E2 is the one that comes from the ovary, which is called estradiol. But the fat cells have the ability to make estrogen. It can convert androgens to estrogen. So in this situation where you have the androgens are high, because that is a mainstay of the polycystic ovary syndrome. When the androgens high, the fat cells that I'd say that most people get fat, and these fat cells, the more fat cells you have, the bigger fat cells. They have the ability to convert the androgen, which is the testosterone, to an estrogen called estrone, which is a bit different from the one that comes from the ovary. And this estrone is a pro-inflammatory estrogen. So people who have polycystic ovary syndrome, they are at a higher chronic estrogen state, chronic inflammatory state. And as I said to you, from remember last week, we said chronic inflammation lead to all kind of things. Diabetes, hypertension, stroke, heart attack, and all set of cancers. So people with polycystic ovary syndrome tend to have high background inflammation, and the increased estrone, which is produced by the fat cells, which are converting the testosterone to this estrogen, is part of the problem there. You with me?
Wow. Yes, yes. So that is quite new, I guess, to a lot of people, knowing that the fat cells in your body can actually produce these hormones. I don't
Yes.
think we actually knew of that. You figure it just coming from your ovaries, right? So the
No, so they call that peripheral. The fat cells convert the testosterone. They call that aromatization, or the peripheral conversion of androgens to estrogen. Okay.
Right. So it's
All right.
excessive exposure to estrogen, and that is also not good, as we discussed last week.
Yes.
Yeah.
So it's a funny situation. The androgens very high, but the androgens very high will then cause increase of the bad estrogen, then, right?
Yes,
Which
yes.
is estrone. We're causing increased inflammation, right?
Yeah, yeah.
Which eventually can lead to the other things, okay?
Right.
Like stimulating the lining of the womb to become cancerous.
Right.
And remember last week we said that people who are in high estrogen state, they have increased risk for ovary cancer too, fallopian cancer, peritoneal cancer, rectal cancer, colon cancer. So all of these, the people who have bad polycystic ovary syndrome, who have high androgens, they will have also high exposure to estrogen and low progesterone. And this is a cocktail for increasing your risk for all of the estrogen sensitive cancers.
Yeah, okay.
Is that clear?
Yes, that's clear. We covered quite a bit of this last week. People can drop in the chat. We'll go through some questions towards the end. Some people have questions.
A little bit more from this chart, flow chart that I draw, right?
Okay,
so remember we said that the increased estrogen have a negative feedback onto the pituitary gland, and that could decrease the follicle stimulating hormone.
Right.
The decrease in the follicle stimulating hormone will cause the follicles in the ovaries not to develop and to die. They call that atresia. Then that will lead to anovulation. So you're not ovulating, you're not releasing the egg. So if you're not ovulating, this is how it causes infertility, because you need to release the egg for the egg to be fertilized by the sperm for you to get pregnant. But if you have an ovulation, there's no egg. So this is how it can cause infertility. Okay?
Okay.
So, and these people now will have irregular periods because they only have a period when you get ovulation and when you get a corpus luteum form that have the progesterone. And if you're not pregnant by day 21, the progesterone level will fall because the corpus luteum die, and then by day 28, it's shed as the period.
Okay, cool. So if you're missing your period, you're to check your doctor. If
you're missing your period. Other things could cause you to miss period too, you know. So the polycystic ovary syndrome, you have to rule out other things. If somebody come and not having a period, the first thing you have to do is do a pregnancy test and make sure that they're not pregnant, because if they're pregnant, they're not going to have the period, right? Right. Then the pituitary gland have another hormone called prolactin. And that is, remember last week we talked about the prolactin? Prolactin, yeah. Cause the breast to cause the milk going. The milk, and if the prolactin is an antagonist of estrogen, so the longer you breastfeed, the higher the prolactin is there. So that will antagonize the tendency of estrogen to want promote cancer, right? Right. So and give you some protection. You could have what you call a pituitary adenoma, a benign tumor of the pituitary gland that oversecrete the prolactin. This could also cause you not to have any period, because it's like the higher centers of the brain sense the prolactin, the high levels of prolactin, and believe that you're breastfeeding, and it don't want you to be fertile to get another pregnancy while you breastfeeding and taking care of one baby. You follow me? Right. Okay. So the higher centers of the brain don't want you to be fertile when you're breastfeeding. So the higher centers in the brain now don't know that is the pituitary adenoma over secreting the prolactin. That's causing so it's like the higher centers of the brain believe that you're breastfeeding. Right. So it don't want you to be fertile. Right? Right. So this is the next thing again that will prevent you from ovulating. Okay. And not having no period. Okay. Okay, an issue with the pituitary gland. Wow. Could also cause you not to have period. There are many other things there. You have some you might have a tumor from the adrenal gland that over producing androgens, testosterone, and if if the tumor in the adrenal gland producing plenty testosterone, it could tie into the same thing and make it look like it's polycystic ovary syndrome, when it is something, there's a rare one, but it's very common to have a rule out, something called congenital adrenal hyperplasia. I don't want to get into it. If it was doctors are talking to, I could have get into that, but I don't want to get into it, okay? So it could, will lead to irregular periods, and the irregular periods telling you that you're not ovulating. So those who ovulate 4, 5, 6, 7, 8 times, they can get pregnant, but at a lower frequency as opposed to the person who ovulating 12, 13 times a year. Okay?
Okay.
So some people, those people will have what is called subfertility. Those who have total amenorrhea, no periods at all for many years, they're not ovulating at all, and they will have infertility. So those people, unless you give them things to stimulate them to ovulate, or the life cycle change, to change certain things to optimize the situation that they will ovulate, they will not get pregnant. All right?
Right.
I'm hoping people following me, because I had to spend time trying to draw out these things to see, to tie up everything. Okay?
Okay, so Doc, so just to say, one of the most common symptoms then is the lack of seeing a period.
So the common
one.
The commonest symptom is what we call oligomenorrhea, right? Which is less than around 9 periods for the year. Okay?
Okay.
So most people will have that. All right. Most people will have features of testosterone.
Yeah. The hair,
mustache, the beard, the acne, the chest hair, the abdominal hair. Some will have the clitoromegaly. Some might have the alopecia, the male pattern baldness. Most people will get obese because of the reasons that don't explain before. Some people might have hoarse voice, that kind of thing. Okay?
Right. So ladies, those are some of the symptoms. If you see them, go check your doctor. Don't be happy that you're not seeing a period.
All right. Another main thing is because of this insulin resistance, you get high insulin, the pancreas putting out high levels of insulin. If the insulin level is high chronically, it can cause the skin to get very dark and thicken, something called acanthosis nigricans. So most people will have these signs. And you could see like the cheeks get dark, the neck region will get dark and thicken. If you look on the back of the neck, it can be very dark and the skin very thick, and the elbow, right? And
but aren't those symptoms of diabetes as well? The thickening of the skin?
Yes, because see, as I said, this is a continuum. The metabolic syndrome, these people who have the polycystic ovaries, they basically have insulin resistance, and a lot of them will have metabolic syndrome. So they're on a treadmill down the road to diabetes. If they don't do certain things to modify the environment and step off of the treadmill. Okay? So as you just rightly said, that these are the same kind of symptoms to people who develop type 2 diabetes.
Right.
So a large proportion of the people with polycystic ovary syndrome, if they don't do certain things to keep it in check, they're at high risk to develop diabetes and hypertension down the road.
So let me ask you another question. So earlier you mentioned that there's some other for example, issues with the adrenal glands, the tumor, the pituitary glands, could be the underlying issue versus polycystic ovary versus insulin resistance and other things. How would is it blood work that would help doctors to diagnose this? Can you get misdiagnosed?
Yes. I don't want to get into it, as I said before. But
what I want to know is, can I get misdiagnosed, and instead of treating my tumor, I'm being treated for something else? If I have a tumor on my adrenals.
If people follow the Rotterdam criteria, you won't get misdiagnosed. So those out of 3 things, right?
Okay.
You have to have the features of menstrual abnormality. You have to have the features of androgen excess. And some people will have the classic polycystic ovary syndrome. Okay?
Okay.
All right. So if people stick for 2 out of 3 of this, you won't be misdiagnosed. Okay. However, I tell you, some of the adrenal things could mimic, right, some of the features of polycystic ovary syndrome. But if you have adrenal hyperplasia or you have a cyst that overproducing the androgens, your ovaries will look normal.
Okay,
Okay?
so the ovaries will be okay.
Normal. And your most and a lot of these people probably will not have the amenorrhea or the oligomenorrhea. Okay?
Okay, okay.
All right. So let me try to tie up some more. Another second flow chart here. Right. So the things that I said before, obesity, the hairiness, the acne, not having regular periods. So the problems are how you look. People might have a poor body image because especially around the belly, a lot of the fat is put on around the belly because remember last week we talked about subcutaneous fat and visceral fat.
Visceral fat, yeah.
So these people have a large amount of visceral fat. So it's fat. You might get something called acute fatty liver if they're eating bad and not exercising. Remember last week we talked about the fruits and the
yes, and the fruits,
that
yeah,
have
the
the
sugar
glucose and the fructose.
and the
all right?
glycemic index, yeah.
Yes. So the same thing, all of these apply here, and you could get acute fatty liver. And if it is chronic, eventually it damages the liver. You could end up with liver cirrhosis, just like somebody who's an alcoholic, right? All right. So in order, we want to get down to how we treat things now, okay?
Right, how we treat it, yeah.
How we treat it. So
I think
because most people eventually get overweight or obese, I think the most important thing is regular chronic exercise. That is what I tell my patients, okay? So they should start with just, I normally check their height and their weight and work out their body mass index. So we have that as a baseline. Then I will give them a cocktail of things to do and for at least 4 months, and then they return in 4 months. And the first thing I want to see is the weight, to see if the weight coming down. Because if they comply and do all the things I ask them to do, the weight will start to come down. All right? And if people wasn't having period, most of them will start to have period. If the period was irregular, the period will start to get regular. All right. So the first...
and that is without medication?
Without any medication.
Okay.
So the most important thing is regular chronic exercise. People need to start to walk for at least half an hour and try to do that every day. And as you get fitter, walk faster for the same half hour or walk longer. So you have to increase the load. And if you find that you're walking now really fast, sweating, breathing heavy, and you're going for like all an hour and thing, that is very good. But then you could start, once you get fitter like that, you should start to add weight training, which is called resistance training. Remember last week we talked about weight training and that the weight, if you're lifting weights, then you build muscle as opposed to fat. So you have the fat compartment and the non-fat compartment. So your weight could remain the same, but if you reduce the fat compartment and increase the non-fat compartment, you're in a better metabolic state. The non-fat compartment is muscle, bone, cartilage, ligaments, all those kind of things, okay?
Yeah. So someone asked, Doc, to that question, if you have been diagnosed with a PCOS and the doctors prescribe metformin and birth control.
We come into it. Okay. We come into it. It's a stepwise thing. So the most important thing, and probably some of the doctors not telling people this and just go straight to metformin or go straight to letrozole or go straight to clomiphene or go straight to ovarian drilling. That is not good. Because I hardly do any of those things. Just by following what I'm putting out here, most people who come to me will improve significantly. They will lose weight. Those who wasn't getting pregnant, most of them, 70–80% will get pregnant, sometimes fairly quickly too, less than 6 months without any ovarian stimulation or anything, okay?
Wow,
so what I'm saying here is from my experience and my practice, and I know it works, okay? So, the regular chronic exercise should be combined with what is called a low glycemic index diet or a ketogenic diet. And that is just saying reduce the simple carbohydrates, the things then that converted to glucose quick within 2 hours after eating it. The rice, the flour, the Irish potato, they don't have much fiber. Right, so they digest it quickly and within 2 hours push up the blood sugar very high. And as I said before, the insulin already high. It's going to put too much glucose into the cell. The cell going to have to convert some of it to fat, and then with visceral fat gone up and that and so on. And I remember the visceral fat produce some chemicals. We mentioned this last time. Produce some chemicals called cytokines, right? Interleukin 1 and interleukin 6, and something called tumor necrosis factor. Is a whole host of them. And all of these things are the mediators of chronic inflammation. So if you have chronic inflammation, you're setting yourself up for diabetes, hypertension, and a whole host of cancers. You with me?
Yes, so, I'm with you. So I know a lot of people
need to get rid of the low glycemic index diet. Don't drink sweet drink. Don't add sugar to nothing. Right? Try to reduce your exposure to sugar. Don't eat too much sweet fruit. Right? You're not going to sit down and eat 6 Julie mango and that kind of thing. Or eat a sweet whole papa.
Doc, I love to do that.
No, well, it's not a good thing. It's not a good thing.
Well, I exercise after.
All right. So when you combine the regular chronic exercise with the low glycemic index diet, or what is called a ketogenic diet, is one where you have plenty proteins and plenty fats. Over 90% of the diet is that. And then, like I said, less than 10% is carbohydrates. Carbohydrates is what break down to glucose. Okay. All right. And the glucose is the stimulus for the pancreas to secrete more insulin. And we don't want the high glucose and the high insulin, because that will lead to obesity and compound the problem. Right. The third most important thing that I will tell people is metformin. Now you have other things people might ask about, berberine and inositol and rah. I stick to metformin, because metformin is the drug of choice. We know how it works to a large extent. It's by and large very safe. Millions and millions and millions of people have used metformin over the last 80 years because it's a frontline treatment for type 2 diabetes. So we know that it's relatively safe and it works. It works in many different ways, and many ways to help with this particular syndrome. It helps you to lose weight. It increases the insulin receptor sensitivity. So if the insulin receptor sensitivity is increased, then the pancreas will reduce the amount of insulin it's producing. If the pancreas reduces the amount of insulin it's producing, this will augurs better for people to lose weight easier. You understand what I'm saying here?
Okay, yes.
All right. So the metformin, one of the main things that it do is it increase the insulin receptor sensitivity. And once that happens, you're going to have decreased insulin production by the pancreas. And the decreased insulin production will decrease the androgen production. Because the first chart I show you, both high insulin and high estrogen can actually increase the androgen, right?
Right.
All right. And the high luteinizing hormone cause the ovary to produce excess androgens, and then the fat cells can change the androgen to estrogen. So if we have low insulin, we will have lower androgen production. And the lower androgen production, all of the things like the hirsutism, the eeriness, the acne, the excessive weight, and the coarse voice, and the alopecia, and the central obesity, all those things will improve.
Okay.
Right? So the metformin is crucial, just because one of the way it works is by increasing the insulin receptor sensitivity. And once we do that, that is one of the root cause for the polycystic ovary syndrome, metabolic syndrome too. So the metformin is crucial for all of these syndromes.
Okay.
All right.
So yeah, somebody had a question on that. So, and they spoke about the birth control too. Apparently they're on both. So they wanted to know if they should come off.
Following this in a sequence.
Yeah.
And if any doctors on this site that suggest, I don't want to sound full of myself, what I'm saying here and no work. It works.
So I think we have Dr. Wynn. She's on.
So once we reduce the weight, the reduced weight is also tied up with reduced fat, okay? So the weight loss is mainly fat loss.
Okay.
Now, we don't want to lose muscle and bone and cartilage. So the weight loss is also fat loss. And that now, because you have reduced amount of fat, what that will do is reduce the peripheral aromatization. Because remember I said to you that the fat people, the overweight or the obese people have plenty fat cells. And these fat cells have the ability to convert the androgens that the ovary is producing to fat.
Okay. Okay.
No, to estrogen rather, right? And that estrogen is the bad one, which is called E1 or estrone, which is pro-inflammatory, right? So what I'm saying here, by using the exercise, the ketogenic diet plus the metformin, all of these will result in reduced weight. And that reduced weight now will cause reduced estrogen production. You will have reduced estrone because the fat, you don't have as much fat cells to be changing androgens to estrone.
Okay.
You following me?
Yes, yes.
All right. So by reducing the estrone there, we then reduce the endometrial hyperplasia because the excessive estrogen, both E1 and E2, but particularly the E1, which is produced by the fat cells, it can stimulate overproduction, like it stimulates the lining of the endometrium, and it gets what we call hyperplasia. And if you have hyperplasia, that is a precancer lesion. And if it stays long enough, this situation stays long enough, it can eventually lead to the production of endometrial cancer.
Wow.
You with me?
Wow, yeah.
So by just losing the weight, you're also reducing your estrogen and reducing your risk of all of the estrogen sensitive cancers, particularly endometrial cancer. Okay.
So ladies, yeah, so for my ladies here, that's very important.
So those, yeah.
Excessive exposure to estrogen. These are many ways in which you can protect yourself against that. So please take what Doc is saying seriously.
All right. So
better to prevent than pay to fix.
So the 1, 2, 3, 1, 2, 3 there, just by themselves, will go a far way to reverse this syndrome. Regular chronic exercise, low glycemic or ketogenic diet, and start them on metformin. If the person is obese, metformin, about 20% of people go on metformin, will get a kind of gassiness or diarrhea or bloating. And especially the diarrhea can cause people not to want to take it. So the metformin is the generic, and the people who take in the pure metformin have a higher incidence of these side effects as opposed to people who take in a brand called glucophage. So the glucophage brand, which is metformin, the diarrhea and the gassiness and bloatiness is less with that brand. And what I usually do, I try to wean people onto it. So the ones who are overweight, they need to take like about 500 milligrams of the glucophage 3 times a day. But if you start them de novo straight on that, most people, 20%, 30% will get these bad side effects and will stop taking it. And you don't want them to stop taking it. So I usually ask them to take 1 glucophage, which is 500 milligrams of the metformin per day for like 7 days. And so you're introducing it gradually. After that 7 days, I will ask them to go to twice a day. So they will take it twice a day, usually with meals. So say that they take one with breakfast or with lunch and the next one with dinner. All right. And say 12 hours apart. And once they stay on that for around 14 days. So we reach 2 weeks now. So 1 week and the one alone, 2 weeks and the 2. And if they're tolerating good, I ask them to go up to 3 times a day. So they could take one with breakfast, one with lunch, and one with dinner. All right. And so when they take 3 times a day at that level is when it's most effective in increasing the insulin sensitivity and in reducing the androgens and eventually reducing the weight because you reduce your fat.
Okay.
You following?
Yes, yes, Doc.
All right.
Well.
Now we're going to number 4. So 1, 2, 3 is regular chronic exercise, low glycemic index, then glucophage, metformin. Number 4, for those who don't want to get pregnant, is the combined oral contraceptive.
Okay.
So combined oral contraceptive have estrogen and it have a progesterone. Every one of them have a progesterone. Now the best one for the people who have bad polycystic ovary syndrome is one called Dee and 35. The Diane 35 have 35 micrograms of estrogen named ethinylestradiol, and it have a progesterone in it called cyproterone acetate. Now, this progesterone is a very strong anti-androgen, is an anti-testosterone. So that make it the best one, because a big part of the problem is the excess testosterone.
Right.
So if you have progesterone, which will antagonize or nullify the testosterone, it is good. So all of the problems that the excess testosterone causing, nullifying that with the Diane 35 will improve them.
Keep it feminine.
The acne and the eeriness and some of the obesity and all of the them that the testosterone that causing. The pill can nullify it. Any pill will nullify it, right? But the Diane 35 is the best one because the progesterone that it have called cyproterone acetate is a powerful anti-androgen.
Androgen,
That one called Yasmin. That one have a progesterone in called jospirinone, and that the jospirinone is another anti-androgen. So metformin, not metformin. I just said the name. What the name I just said? Yasmin.
Yasmin
is also a good one. And it will, because it antagonizes the testosterone, it will also facilitate you losing weight. Right?
Okay. I'm sure many people didn't know that.
The go-to one, the best one is the cyproterone acetate. That is what in Diane 35. And the next best one is the Yasmin because it have the jospirinone. All right. Now, for the people who wasn't having no period at all, and some people like to have period because they believe something really, really wrong if they don't have no period. The pill, any pill, will cause you to have what is called a withdrawal bleed. So like the period would come back then. So people they have anxiety and all kind of things because they're not having the period. Once they go on the pill, they will start to have a regular withdrawal bleed, which stimulate the period, right? So like the Diane 35 is 21 tablets. Or if you use a low dose pill like Novinet or Lindinet, those are all 21. So you start the pill on the first day of the period and you take it for 21 days straight, and then you stop for 7 days. When you stop for the 7 days, just like what I mentioned up front with the menstrual cycle, once the corpus luteum die and the progesterone level fall, it will come to a point where it cannot maintain the lining of the womb and it shed as the period. So that is the same thing will happen here, because the pill have the estrogen and it have the progesterone, and you take that for 21 days. But when you stop, the progesterone level will fall and it will reach to a point where it cannot maintain the lining of the womb and it will shed, which is real term is a withdrawal bleed, but that simulate the period. You with me? You with me?
Yes, Doc, yes.
All right.
Yes.
Okay. All right. So the combined oral contraceptive is very important for many reasons. Okay. All right. So as I say, it can reverse or ameliorate most of the problems caused by the increased androgens. Okay. And if you reduce the androgens, remember what I said that the androgens could do to the liver. It could cause the liver to reduce the sex hormone binding globulin. And when the sex hormone binding globulin is reduced, you increase the free androgens and estrogen. So the pill will reverse that because it ameliorates and antagonizes the androgen. So the liver will now start to produce the sex hormone binding globulin again.
Okay.
And the sex hormone binding globulin will tie up a lot of the estrogen and also the androgen, right? Okay. So you do have plenty free estrogen, which will usually have this feedback on the pituitary gland to cause it to produce more luteinizing hormone. So when you reduce the free estrogen, you will actually reduce the luteinizing hormone from the pituitary gland now.
Okay.
All right. And remember from up front with the first flow chart, we said that when the luteinizing hormone is high, it stimulates the cells in the ovary that produce androgens. Okay.
Right.
So we all know the androgen coming down. The pill is antagonizing some of it. And by antagonizing it, it free up the liver now to produce more sex hormone binding globulin, which
Right.
tie up more androgen and estrogen, which will cause the luteinizing hormone to fall, right?
Right.
And reduce the ovary from producing more androgen. Okay?
Right.
So the pill touching off many, many things. Okay? All right.
So
So
this pill is very beneficial. I know last week we
it's
touched on
very,
it a
very
little bit because
beneficial.
there's a lot of myths around the pill. Some people don't want to take it for
Yeah.
fear of, you know, repercussions down the road. So ladies, it protects you from much.
So they see, because the pill now reduce the estrogen, especially the free estrogen, all the problems that estrogen cause will be improved when you're on the pill. So like we say now, you have decreased estrogen. The decreased estrogen now will cause decreased sensitization of your breast and your fallopian tube and ovary and endometrium that can initiate the carcinogenic process that can cause cancer 10, 15 years down the road. Okay? So the pill, this is, remember last week I tell you that the pill is one of the best things to take to reduce your risk for ovarian cancer.
Yes, yes.
Well, this is how, this is one of the ways where it works. By reducing the estrogen, right? And reduce the free estrogen so that it can initiate the cancer cascade.
Right.
Okay?
Right.
All right. So that is number 4. People go on the pill. But you can't put somebody on the pill who want to get pregnant. So if somebody want to get pregnant, so they come in, they're suffering from subfertility or infertility, and they want to get pregnant, you can't use the pill. So then we will go to number 5.
Okay.
In the management, right?
Right.
So for those wanting to get pregnant, we should use something now. There's a drug called letrozole, and there's one called clomiphene. Now, most people will go to clomiphene, but the drug of choice should really be letrozole, because letrozole is what is called an aromatase inhibitor. The enzyme in the fat cells that convert the androgens to the estrogen is called aromatase, right?
Okay.
So if
These are some big words, but
yes. So I know that's why I tell you, say to be easier talking to doctors, right?
Yeah. But
we
we're getting it though. We're getting some, especially when you break it down.
Say that one of the main problem with this thing is the increased production of testosterone. And the testosterone can be converted to estrogen, the bad estrogen named estrone by the fat cells, right? By a process called aromatization. So the aromatization need an enzyme. An enzyme is a chemical that catalyzes a reaction. So it needs an enzyme called aromatase to convert the testosterone to the estrone.
Okay.
Yes, so letrozole block that enzyme. So when you block that enzyme, you can't convert the androgen to estrone.
Okay.
Right?
Okay.
So if you can't convert the androgen to estrone, basically you reduce your estrogen, especially the bad one, E1, which is the estrone. So then you're going to reverse the feedback onto the pituitary. Remember we said that the free estrogen particularly will cause decreased follicle stimulating hormone, right?
Right.
It cause a negative feedback on the pituitary gland. So when you reduce your estrogen, particularly the estrone, this negative feedback is reversed. So the pituitary gland now will start secreting follicle stimulating hormone again.
Okay.
And this follicle stimulating hormone will cause the follicles to develop in the ovary normally.
Okay.
And can lead to ovulation.
Okay. Okay.
And if you get ovulation and you have good quality sperm, then you can get pregnant.
Okay.
But this is how the letrozole work, right?
Okay, so for those who want to get pregnant,
yes, for those who want to get pregnant. The good thing with the letrozole is that you usually ovulate, just one egg will be released, right?
Okay.
When you use clomiphene, the clomiphene also stimulates ovulation, but it can stimulate 4, 5, 6, 7, 8, 9, 10 follicles to ovulate. Okay. So if you get excessive ovulation, there's an increased risk of having multiple pregnancy.
Okay.
As much as about 8% of the time you could get multiple pregnancy. Twins or triplets or sometimes even quadruplets and things. And you don't want that to happen.
Okay, so
All right.
ladies, it's important to know what you're being given.
So the letrozole would be my go-to one, and secondarily clomiphene. But the letrozole is available, it works good, and it causes one follicle to be ovulated. We could touch a little bit on the clomiphene. So it's clomiphene citrate is the other thing you can use to stimulate ovulation. And this is a weak estrogen. So what it does, it go and sit down on the estrogen receptor and block the real endogenous estrogen from stimulating. Okay? So in a sense, it's like, all right, they say that the real estrogen is a key to open the lock, to open the door, so that certain things happen inside of the cell. Right. If I have a key that can go into the lock but can't open the lock, right? It just go into the lock, can't open the lock, but it block the real key from coming into the lock.
Okay.
You understand me?
Okay.
So they call this a competitive antagonist. So the clomiphene citrate, being a weak estrogen, it sit down on the receptor and block the real estrogen. So what it do is like it antagonize the estrogen. Okay?
Okay.
All right. So by doing this, it antagonizes the estrogen, so it removes the negative feedback that estrogen have on the pituitary gland. Okay?
Okay.
I just mentioned that. It removes this negative feedback. And by removing that negative feedback, the pituitary gland will now increase the follicle stimulating hormone, which can cause the follicles in the ovaries to develop and can lead to ovulation. Okay. However, you can get more than one follicle ovulating, right?
Okay.
And because this, you could get multiple pregnancy, as much as about 8% of the times. So you get more twins and more triplets.
Okay.
All right. So another thing that could happen is that because it's blocking the estrogen, especially if the person is an older person, it could start to cause some of the menopausal type symptoms.
Because what you call older, what age you're talking about?
40s. Say 40. Somebody in their 40s, and you're using this because it's blocking the estrogen. The ovaries probably starting to fail. You're probably getting perimenopausal, and you're not producing as much estrogen, and then you're bringing something that blocking it. So some people might start to get like hot flush and night sweats and mood swings and them. So these are some of the side effects of the clomiphene citrate, right?
Okay.
And there about 1% of people would have something called ovarian hyperstimulation syndrome. And that's why I get into it. Yeah. If it was a doctor talk, we'd get into it. But this could be a serious something, could even be life-threatening. All right? But just about 1% of people get it. Everybody with me, dear?
Yeah. Doc, someone has a question.
Remember last week we said that they used to believe that things like clomiphene, because it caused excessive ovulation, which every time you ovulate, you traumatize the surface of the ovary. And you traumatize the surface of the ovary, it have to heal with cells turning over. And once you have increased turnover of cell, there could be an increased risk of a false copy called a mutation that could lead to cancer. So they used to believe that if a drug causes excessive ovulation, then it could theoretically also increase the risk of ovarian cancer. But over time, this has not been shown to be so. So it's a hypothesis which the real life experience not bearing it out. Okay?
Okay.
All right.
Someone wanted to know, should PCOS patients who are not overweight be prescribed metformin?
I would say yes. Because those who are not overweight, they don't have to go up to 3 for the day, right?
Okay.
Because that is for those who you want to release, to lose weight. So if somebody is not overweight, but they're still not having regular period, so they have menstrual abnormalities, and they still have the some of the features of the androgenism and thing, the metformin will work for them by increasing the insulin receptor sensitivity. By doing that, you reduce your insulin production and all of the problems them that the high insulin cause. Okay?
Okay, yeah.
All right.
Doc, what about Ozempic? A lot of people are using that now to lose weight. Is that?
Yeah, I'm not a big fan of it. Because remember last week we said that even though we should try to lose the weight naturally, with the exercise and the diet and the metformin is safe and thing and so. When people use the Ozempic and start to lose weight rapidly, then they get a whole heap of loose skin hanging off and all that kind of thing. Plus, you also lose from the non-fat compartment, and you don't want to be losing muscle and bone and cartilage and all them things, especially going into old age. That is a very, very bad thing to do. So I am not a big fan of the shortcut to start the Ozempic, because you're going to be losing. So some evidence is as much as 40% of the weight loss is muscle loss, and that is not good.
And how long should one remain on metformin?
Well, I am taking metformin for at least 15 years now, and I do have polycystic ovary syndrome. I am not overweight. Metformin have a whole host of benefits, right? Just take it from me, metformin is a proven anti-cancer drug. So people who on metformin, they reduce the risk of cancers. And I just explained already one mechanism in which it could work by reducing the exposure to estrogen and also reducing insulin, because both estrogen and insulin are pro-mutagenic and can promote cancers. Okay?
So you don't have to be overweight to take metformin then, you're saying?
No, you don't have to be overweight. And I'm telling you, I take one every day. About 10 years ago, when I was a bit bigger, I used to use 2. But once my weight come down now, I am at 23 kilogram per meter square. I don't need to lose any weight. So I just take 1 glucophage every night. And that one, at the dose I'm taking it helps to reduce cancer, not just from the low estrogen or insulin. It will get more difficult. It switch on a molecule, well, a gene called AMPK. It will get too complicated. I don't want to get into it.
Yeah, I get you. Okay.
But it reduces your risk of developing any cancer. Also, it slows down the rate of aging, right? Your chromosomes have something at the end of it called it telomere. I think last week I tried to explain, like, say, look on your shoelace. The shoelace have the ends on it, right?
Right.
If you take the ends off of the shoelace, the shoelace will start to fray out, right? You don't want it to fray out. So the end of the shoelace, that is something equivalent to what we call the telomere and the chromosome. So it prevents the chromosome from unraveling and getting and cause mutations that can lead to cancer.
Okay,
and
well,
the longer the telomere is, right? And the longer you have good telomere and not shortening, is you get your age slower.
Right.
Right.
And I saw where sleep as well. If you get good sleep, your telomeres are longer too.
But remember last week we talked about the importance of having at least 7 to 8 hours sleep. So that is part of the whole thing too in dealing with polycystic ovary syndrome. Okay.
Okay.
All right.
And I guess if you have the symptoms or problems with the metformin, as you mentioned, there's ways you can take it to reduce the diarrhea and the flatulence.
Yes. So if people get eased into it, most people will eventually tolerate it good. Or if people definitely, even after a long period of time, can't tolerate the 3, they will tolerate the 2. And if they tolerate the 2, but they're supplementing the thing by using the pill, if they don't want to get pregnant, the regular chronic exercise, eat the low glycemic index diet, or the ketogenic diet. If they have to use carbohydrate, use complex carbohydrate. Any kind of yam, cassava, sweet potato, breadfruit, tanya, eddas, green banana, all those things have plenty fiber. So they're harder to digest than the rice, flour and Irish potato. So when you eat them kind of ground provision, especially with like green leafy vegetables and things, these don't digest fast. They digest slowly. And like the green leafy vegetables, you can't digest them really. So that get down into your colon, where trillions of organisms called your microbiome down there will digest it, release the nutrients to you. They want this fiber, so they feed on the fiber. That is what feed them. So when you eat the yam and Irish sweet potato and cassava and them things, you have plenty fiber, which you feed in your microbiome. So those people who feed the microbiome and have the good thing down there, reduce the sugar. The plenty sugar and the simple carbohydrate encourage the bad microbiome. Yes, we cause chronic inflammation and other things. But when you encourage plenty fiber, green leafy vegetables, you encourage the good microbiome. So all of the acid reflux and the irritable bowel syndrome, all those things can disappear. And the weight will start to come off. You're much healthier. You're reducing your risk for getting cancer. You're stepping off of the treadmill. That leading to diabetes and hypertension and cancer. Okay?
So, Doc, someone wants to know, where do you get the genuine metformin in Trinidad? And I guess Jamaica as well. Is it widely available in the Caribbean?
You can get generic metformin easy. And it's very cheap. But
the generic works as the genuine one?
No, the metformin is the generic. That means the real drug. But when you put it together in a formulation, which is called glucophage, that is better tolerated. So I hardly write pure metformin for anybody. Because if they won't take it, it's not going to help them. So if they use the glucophage and we not onto it, like I said before, most people will tolerate it and they will get the benefit.
And it's readily available. And it's available.
Readily available, yes.
Okay.
That every pharmacy in Trinidad will have glucophage. Everyone.
Okay. And it has to be issued by prescription, right? Prescribed.
It should be by prescription, but I'm sure people will get it over the counter, but it really should be by prescription.
Okay. All right.
All right. So let me just try to come back again. So we finished 5 things, right? The 5 things are, well, first thing we said, the regular chronic regular chronic exercise, the ketogenic diet or the low glycemic index diet. Number 3 was the glucophage or the metformin. Number 4 was the combined oral contraceptive for those who don't want to get pregnant. Number 5 was the letrozole or the clomiphene for those who want to get pregnant, because those will encourage ovulation, right?
Right.
Number 6 will be what is called laparoscopic ovarian drilling. Now, a lot of doctors go straight to this, and I don't subscribe to that. It's a long time I have never done none of this, right? I reach to the point now where I'm saying that it is not actually necessary. And it can cause certain problem, because some people, if you have there's something called the diathermy, is a needle that generates energy, like heat, right? And you use this needle to puncture the ovary. Now, if you have the diathermy and too powerful a setting, you could do too much damage when you burn the ovary, right? Or you probably you can be overzealous and do too much drilling. So say somebody might have it on an eye setting and they drill say 6 or 7 or 8 or 10 holes in the ovary. That might be all right, but somebody else might have it on that very high setting and drill 15 or 20 holes into the ovary. Because what this do, you're trying to destroy the stroma of the ovary, which I tell you have the cells them that can produce the androgen. So what you do is destroying some of the stroma of the ovary and reducing the amount of androgen that the ovary produce. And by decreasing the androgen, you should understand by now all of the benefits that cause. Okay?
Right, exactly.
Yes, because that that can allow people to ovulate. And if they ovulate now, they could get pregnant. Okay?
Wow, okay.
But we don't have to go there, because all of the 5 things that we said before, most people will lose weight, and most people will ovulate, and most people will get pregnant, and most people will keep the pregnancy.
Right. So ladies, there's a lot of hope for those of you with diagnosed with PCOS. So
It's a lot of things I just explained there a while ago.
Yeah.
Now, the metabolic syndrome, that is 3 out of 5 things. If you have 3 out of 5 things, we say you have the metabolic syndrome.
Yeah.
So the 5 things are triglycerides. Triglycerides are some bad fats in the blood. You want to have it very high, right? So if people have greater than or equal to 150 milligrams per deciliter, right? That is not good. You want the triglyceride to be lower. Then if you have the high density lipoprotein, which is the so-called good lipoprotein, good cholesterol, if you want that to be higher. But in the metabolic syndrome, it is low. It is less than or equal to just 50 milligrams per deciliter. All right. That 2 things there, what I just said already, is very bad, because one of the marker that you can use to see if you have a high risk of getting cardiovascular disease, means stroke and heart attack and those things, is the ratio between the triglyceride to the high density lipoprotein. So when you do your lipid profile, if you check the triglyceride and then you divide that by the high density lipoprotein. So say for instance, your triglyceride is 100 and your high density lipoprotein is 100. That ratio of the triglyceride to high density lipoprotein will be 1, and that will be very good, because if it is less than 2 or even less than 1.5, it increases your risk. It is a marker that that person is at low risk to get stroke and heart attack. So in the metabolic syndrome, what we're saying here now, if the triglyceride is 150 and the high density lipoprotein is only 50, that ratio of triglyceride to high density lipoprotein would be 3. You're following what I'm saying here? And if the ratio is more than 2, it increases your risk for stroke and heart attack and other things.
Yeah.
All right. So the third thing is that your fasting blood sugar. So you fast for 12 hours and take the blood sugar, it is higher. If it's higher or equal to 110 milligram per deciliter, that is not good. Right? It really, your fasting blood sugar should be less than 100. It would be nice if it's all down to 80 or 90. But if it's over or greater than or equal to 110, that is not good. Now, your blood pressure will also go up. So I tell you, all of these things tie up. So the blood pressure would be greater than or equal to 130 over 85. So that is like borderline hypertension, right, for most people. If it's greater than 130 over 85. And then that is the 4th one. The 5th one is the waist circumference for a woman. You don't want it to be greater than or equal to 35 centimeters. So that means those people greater than, not centimeter, 35 inches. That means they have central obesity. So the 5 things are triglyceride greater than or equal to 150 milligram per deciliter, high density lipoprotein low, less than or equal to 50 milligram per deciliter, fasting blood sugar high, greater than or equal to 110 milligram per deciliter, blood pressure high, greater than or equal to 130 over 85, and the waist circumference at the umbilicus is high, greater than or equal to 35 inches. If you have 3 of those, you have the metabolic syndrome.
Okay.
I hope that was clear.
Yes, that was clear. That was clear. That was clear.
There is also something else called the Ear-Hand syndrome. H-A-I-R-A-N-N syndrome. And the HA, that just means hyperandrogenism, which we were talking before. The people who have high androgens, and the high androgens will lead to ISE1, which is the estrone, which is not good. So the Ear-Hand syndrome, the HA mean hyperandrogenism. The next word is IR, that means insulin resistance. And then the last one is AN, that means acanthosis nigricans. And as I mentioned before, if you have insulin resistance, you're going to have high insulin because the pancreas trying to jumpstart the lazy insulin receptor. So insulin very high. and the high levels of insulin stimulate you have some cells called some cells in the skin will produce excess melanin. The melanocytes will produce excess melanin, so the skin get dark, and you get something called, and it also get thickened, right? So you get acanthosis nigricans.
Right,
so
that we discussed earlier.
The ear-and syndrome mean those things: hyperandrogenism, insulin resistance, acanthosis nigricans. So the round the neck is dark, the back of the neck dark and thickened, the elbow dark and thickened. And this is a marker. The acanthosis nigricans is a marker for insulin resistance. So anybody come and you see the dark area by the elbow and the back of the neck and things, and on the cheek very dark, it means that these people have insulin resistance.
Okay.
And the insulin resistance means that they have high insulin. Right?
And that's for men as well, right?
That's for men too.
Men as well.
So men have the insulin resistance syndrome. So they don't have no ovaries, so they don't have polycystic ovary syndrome.
Right.
But the same things them here. If them have hyperandrogenism, them have the insulin resistance, they have the acanthosis nigricans, is the same things. Okay?
Okay.
And they get the fat around the bowel, which is the visceral fat, and with the visceral fat cause the cytokines, which are the mediators of chronic inflammation.
Okay.
And it's a cascade.
Cascade, yeah.
And the people who have plenty fat, the big fat with the fat now, I tell you, the fat cells change the testosterone. This is the men we're talking about.
Right.
Change the testosterone to estrogen. So yes, so the man them start have big, like what call gynecomastia, because the estrogen stimulating growth of them, the breasts,
boobs,
right?
Yeah, okay.
And all that kind of thing.
Oh, that's a man boobs.
Yeah, yes,
man boobs.
And thing, yes. And then the increased estrogen that you have with the big belly, with the central obesity, that going eventually cause erectile dysfunction because your testosterone level low. So the testosterone being converted to estrogen. The estrogen causing the man boobs, as you say, and the low estrogen can lead to erectile dysfunction.
Right, and possibly cancers too, because the excess estrogen in the body for the men. Okay.
All right.
But doc, sometimes you try to lose the weight, especially in the belly, and it just won't go. You may lose weight overall. I struggle with that, right? And I don't have a high fat diet. I don't have a lot of sugar. I hydrate a lot, but somehow the middle is just
all right. It can be difficult. So I don't have no problem if people doing everything. So people regular chronic exercise, they're eating a ketogenic diet, they're using the glucophage, they're using the pill, and all the things that are supposed to cause the weight to come down, and they still end up having, like, they might have acute fatty liver and they're having visceral fat and that kind of thing. Then
well, I'm not on the glucose.
People could resort to surgery. You could do what them call bariatric surgery, which is, so you have many different ways you can do it. You could bypass the stomach and go straight to the small bowel, or you could shave off some of the stomach, make the stomach smaller. All of these things will cause people to lose weight, but they will lose the weight very quick and drastically. Then we have loose skin, and kind of,
If you try the Ozempic, because I was thinking of trying that.
Ozempic,
but I didn't know
Ozempic could do that too, but as I'm telling you, it's a slippery slope down to bad things.
Okay, so I didn't know of the glucophage. Glucophage, that's what you call it? The metformin, glucophage.
Yeah. Another thing is that you could do, after you're doing all those things, a powerful thing to do is the time-restricted eating or the intermittent fasting, right? Because if people could just skip, like, breakfast. So remember we say that the best time to sleep is between 10 p.m. to 6 a.m. So you have 8 hours, right? Say you are not a scholar 8-16 fast. So you will eat between noon to 8 p.m. That's 8 hours. And then try to sleep between 10 p.m. to 6 a.m. Then when you wake up, don't eat no bread and no jam and peanut butter or anything sweet or so. Just make a cup of tea. You have your tea and throw hot water on it. You don't have to add no sugar or no condensed milk. So you drink your tea without sugar. So once you have sugar or condensed milk or anything like that sweet, it will break your fast because the glucose is what trigger the pancreas to secrete insulin. So if you drink hot water or with tea or anything like that, don't have the sugar, you won't break the fast. Okay?
So what
If you
about
eat,
this prevailing thing about if you're not eating? Because my trainer is saying that if you skip your meals and so on, the body will retain the fat because it needs it to it will hold on to
no,
the
that is not
fat
true.
if you
That is
skip
not
your
true. So let me
meals.
explain it to you. If you could go to 12 hours without eating, and once you're comfortable, you go to 14 hours, and then you're comfortable, you go up to 16 hours. If you can get 16 hours without eating anything simple carbohydrate or sweet and breaking the fast, you have low estrogen because the glucose stimulate the not estrogen, the insulin. So if you're in a low insulin state, insulin is a growth hormone. Insulin is a storage hormone. So once you have high insulin, as I said before, and have glucose, it's going to put too much glucose into the cell. You understand what I'm saying?
Okay, yeah.
And you're going to use up 10, and then use and for your metabolism, and you're going to convert the 90 into fat.
Okay.
So if people fast and don't break the fast, you could eat even nuts, eat nuts and things, right? So the nuts have proteins and it have oils. So the proteins and oils can stimulate a little bit of insulin, but very low amount.
Okay.
And so the lower amount of stimulation, it won't break your fast really. Okay. Glucose is the big trigger to stimulate the insulin. So if you can keep the insulin low, you will lose weight.
Okay. All right.
So it's a holistic thing. All right.
Yes, I like that. So any more doc? Because we're past our time, way past.
No, this is coming up to nearly 2 hours. So
yes.
I think I tried to cover most of the things I wanted to say.
Yes.
Because if people will just follow through this 4 or 5 step things, right?
Right.
Most people, almost many people come to me, long years trying and getting pregnant, and they won't get pregnant, and they just listen. Regular chronic exercise, change the diet, use the glucophage. Boom, within 3, 4, 5, 6 months, most people will get pregnant.
Right.
And another thing is, they used to tell people once you get pregnant to stop the glucophage is not good. I encourage the people once they get pregnant, they should continue the glucophage. All right, the people who continue to use the glucophage, they have a better chance of carry the pregnancy to term, right? And it reduce the baby from excessive growth. They don't want a macrosomic baby. The glucophage will keep the baby to like a good size, right? Right, a normal size. They won't get too small, that a growth restricted baby, and you don't want a macrosomic baby. So you want somebody like normal size baby, right? And if you can deliver a baby like that, you reduce your risk of priming up the baby to get polycystic ovarian syndrome. Remember we said the fat babies and the too small baby have higher risks of getting the things, right? So the people who stay with the glucophage right through, they have less miscarriage, less stillbirth, right? And the baby have a better what we call intrauterine milieu, and you reduce the risk of them to have polycystic ovary syndrome.
Right, and continue the cycle. So this is very informative, Doc. I think sometimes we don't, and especially for the younger women who are in their prime age for pregnancy, we don't think about those things. What are the things I need to do to prevent this happening to my child later on? We don't think about that, to be honest with you. So this is good information. If you have polycystic ovarian syndrome, if your parent had it before, this is what, these are some of the ways in which you can halt it if you're gonna get pregnant. So there's a lot of information. As usual, we'll have the video edited so that it's in a format that people can, follow through, and we post it on YouTube. So I want to thank Dr. Pottinger for his time tonight. I think we answered most of the questions. Somebody wants to know, could they get at 44, could they still get pregnant? We answered the questions on metformin. And yeah,
not 44 years could get pregnant if she follow all the things I said there.
Okay, so I hope you
And
heard
she will
that.
probably ovulate and thing and so. But the older the person is, you have a natural fall off of the fertility. Plus, there's an increased chance of having like a Down syndrome baby. You have different syndromes that will increase, right?
Right.
That you will have an abnormal baby at 44 years. So usually at 44 years, I really not encourage people, for getting pregnant.
Yeah.
The childbearing is a young people thing. Remember last week we said that if every woman could get 3 children between 20 and 30 and breastfeed them for a year or two, that would be a powerful protection against all of the estrogen sensitive cancers.
Yeah.
Particularly endometrial cancer, ovary cancer, fallopian cancer. Okay.
Right. And someone was debating when you talk about the food that she does not. She's skeptical about the pill. So there must be some natural food because God made it. But what I said to her is the natural way in which we're supposed to be giving birth, we don't do it. And so we may need some help along the way because we're overexposed.
Well, the pill, as I said last time, it is so safe.
Yes.
It's that rational kind of fear that people have. Everybody believe they're going to get clot in them leg and it got broke off, go to the lungs and thing and so. So that a lot of people still extrapolating from the bad old days where you had 50 and 60 micrograms of estrogen pill, right? Diane 35 is the highest estrogen pill right now, but it is still a low dose pill. It only have 35 micrograms of estrogen. And the others like Yaz and Lindinet and Novinet only have 20 micrograms. Whereas something like Yasmin or Microgynon, they only have 30 micrograms. So the risk of having a bad side effect that can cause a big problem is very minuscule. And especially if people will watch what they eat and the regular exercise so they don't get obese, they have a normal body mass index and things. And so all less worry about clotting and embolism and all them things will be very, very low. And the metformin, by increasing the insulin receptor sensitivity, that does reduce the insulin and the whole host of problem that cause will disappear.
Yeah, I like that part. I like that. I'm coming to check you on that. And then somebody wants to know what age perimenopause starts.
We usually say it starts about 45, but it could start as low as 30.
Okay.
I've had people in their 30s,
Without doing a hysterectomy or anything like that?
No, if they're having premature ovarian failure, the best way to manage that is to put them on a contraceptive pill. So you use Lindinet or Novinet or whatever. So you're getting your estrogen and you're also getting your progesterone, which is an antagonist to estrogen and a whole heap of benefit, right? So your hot flush and night sweats and all of the issues that could happen if you have premature ovarian failure, just going on one of the low dose pill will solve the problem.
Okay. So thank you, Doc. I think we're going to wrap it up here. Thanks everyone for their time tonight. I think this was extremely, extremely informative. I learned so much. I tell you, every time you talk to Dr. Pottinger, you're going to learn things that, wow, you didn't know this. And oftentimes I think we we don't think about these things. We just leave it up to the doctor. We just, you know, leave our bodies and whatever they tell us. But if we become more aware, become much more knowledgeable, we can take more precautions and ask the right questions and do the right thing. But I think it all boils down to how we take care of our bodies, how we eat, how we sleep, and you know what we eat, how we eat it, and when we eat it, and when we sleep, and how we sleep. So thank you, Doc. I truly appreciate this. We truly appreciate this information, and we'll get this up on YouTube and share with everyone. Any last words, Doc? Any last questions from anyone? You can unmute yourself and ask a question if you wish.
That I managed to negotiate this very difficult topic, because as them say, it have so many working parts. So what I had to do is, I don't know if you can see this, is a lot of flow charts.
Yeah, Ray told me today working on your flow charts. Yeah.
I had to do
yes. Make it digestible. Well, you could scan some of that for me, Doc.
Right? See, it's a lot of flow charts. Look at this one. It's a lot of different things to try to tie them up. You know what I mean?
Yeah. Okay. I'll come by and take a picture of that. I think I don't destroy it. Keep it. I'll probably check it for
cool.
it. Yeah.
All right then.
All right. Thanks, everyone.
Blessed
I don't know if anybody have
time.
one question. Blessed love. Take good care. Bye, Dr. P. Take care.
Somebody asking, how about a lecture on menopause and heart disease? We can
talk about those. Yes, we'll talk about those. We're going to talk about that. Yes. All right then. Doc touched a little bit on it earlier. Again, it comes down to the estrogen and the protective, how protective it is of us. So we talk a little bit more about that. Trisha. All right then. All right. Take good care. Bye, guys. Yeah.